Welcome back, everyone. It is Wellness Wednesday. We are pleased again to have Denise Ware with us and Cindy Fleming. Last time we learned a little bit about acid reflux. I didn't know anything about it. I'm glad you guys explained it to me. We're going to talk a little bit about diagnosis and treatment today. How do you do that? How do you diagnose people that come in and they say, I've got these? How do you figure out what it is?
Well, first, thank you for inviting us back again today to discuss the diagnosis and the treatment portion of the acid reflux. So one of the tests that we used to use, my first degree was actually as an x-ray tech. So back in the day, a few years ago, we would do a barium swallow, and that was done in x-ray. People would drink the barium, and it was more to look for narrowed areas or strictures or ulcers in the esophagus. Now we have something called a pH monitoring test that measures the amount of acid coming from the stomach into the esophagus. However, the best diagnostic tool that we have is, of course, the upper endoscopy, or EGD. That's the procedure that Dr. Kattapalli does at our center. So that procedure involves a patient being sedated for comfort. Okay. And then during that, Dr. Kattapalli uses a flexible tube with a camera at the end to get on the esophagus and into the stomach. It allows him to look for inflammation, ulcers, hiatal hernias. He can check that sphincter to see how well that is working. And then also it allows him to look for Barrett's esophagus. And we'll talk more about that in a minute. But Barrett's esophagus, if any of those things, anything requires a biopsy, he can do that biopsy while he's in doing the procedure at the same time. And people get results within 3 to 5 days. We
talked last time a little bit about how you can develop this. And some people have their whole... When you get to the point and you think, okay, I need to go see GI physicians and get this figured out, is it just if you keep having these symptoms?
The best time to come to see GI providers at GI physicians is when you're experiencing symptoms often, or more than twice a week, or according to the Mayo Clinic guidelines, greater than 6 months. Also when symptoms such as the chest pain or the burning, especially the chest pain after it's been ruled out by cardiology, or difficulty swallowing, or painful swallowing. So when those things become a nuisance and affect your quality of life.
Okay, and you mentioned Barrett's esophagus. That piqued my interest. Do we know what that is?
So Barrett's esophagus is abnormal lining in the esophagus. The main risk factor is uncontrolled GERD or reflux. So that reflux comes up and damages and scars the esophagus. So the reason that we screen for the Barrett's esophagus is because you're at an increased risk for esophageal cancer if you have it. So that warrants then routine endoscopies for Dr. Kattapalli to go down and check the progression of the Barrett's. A person with Barrett's esophagus has an increased risk of esophageal cancer. Their risk is 1 in 500. Doesn't sound horrible, but someone without Barrett's, their risk is 1 in 10,000.
Oh my gosh, okay.
And you know, Dr. Kattapalli's been doing this for a couple decades, and, and he said, you know, back in the day they would see more esophageal cancers secondary to smoking, but now we're seeing more esophageal cancers with this background history of Barrett's. So even in the last year or two, our office has seen a significant increase in esophageal cancers. So we're very proactive, and we like to get our patients screened for this. Yeah,
now we know what it is, and we get the symptoms. What are the treatment options? What can we do then?
So the most effective treatment option is like lifestyle modification that reduces the peak acid output. So we have the basal acid output, that is just the normal output of acid in our stomach, and then we have the peak acid when we think about food or smell food, the acid peaks. So our goal is to reduce that. So by avoiding certain foods or certain drinks, such as the acidic drinks or juices, orange juice. So eating an orange versus drinking a whole glass of orange juice is a better option. Eating smaller meals more often throughout the day. Quit smoking and stop drinking alcohol. Those also are very helpful with that. And taking steps to lose weight or to not wear any restrictive clothing or belts. Those put pressure on the abdomen, which can cause that reflux as well. Outside of these modifications, we have medications. So we have antacids, over-the-counter Tums, Pepto-Bismol, Maalox, Mylanta, things like that. And then we have H2 blockers, which are acid-reducing medications, such as Pepcid, Tagamet, and Axid. The most potent treatment to reduce that peak acid level is through using PPIs. So those are proton pump inhibitors, such as omeprazole and pantoprazole. And then PPIs are also indicated in the treatment of Barrett's, as Denise had spoke about, helping reducing the progression and damage caused by the Barrett's. And then we have, many people are concerned with taking PPIs for prolonged use.
Sure.
And there are no studies that show that taking the PPIs reduce or cause anemia or cause osteoporosis because PPIs do not affect the basal acid output.
Okay, excellent. It's nice to know you guys are around and you can figure out what's going on and help us out. Thank you guys so much.
Thank
It's
you.
good
You're
seeing you.
welcome.